a little bit on principle and how do we assess video stroboscopy, the clinical applications, and I'm going to add on a few slides on enhanced imaging and a few cases to discuss. As Dr. Nadira had mentioned, multidimensional assessment is recommended, and one of the multidimensional assessment is video laryngoscope, which is important to assess the vibratory or the mucosal wave of the vocal fold. So the principle. Stroboscope is an instrument. Hi, I see Tibun Chin. Tibun Chin has very nice larynx, and every patient who comes through my clinic, I have to show his larynx to say, oh, this is how the normal larynx look like without muscle tension dysphonia during phonation. Long time no see. So stroboscope is an instrument that produces flashes of light. So whenever you add stroboscope to the laryngoscope, which the flashes of light is emitted to a phonating vocal fold, then you can visualize the mucosal wave. We heard about the physiology of voice production, about the closed face, open face, closed face, open face. So I give an example of myself. If I say E, my pitch probably 250 Hertz. What does it mean? I have 250 glottal cycle in 1 second. One glottal cycle comprises close, 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 open a few short duration and close again. So that is one glottal cycle. So if 250 Hertz means 250 glottal cycle in 1 second. So it is impossible for our naked eye to see the mucosal wave. So therefore, the stroboscope make this happen. I show this video. It's not from me. I downloaded it from the YouTube. Illegal, but courtesy of the YouTube. So you see this thing like a fan that has white and black. So whenever it moves quickly, cyclical, at first you don't see the plates, right? It's all white. But then now there's flashes of light onto the moving thing. And whenever the frequency of flashes of light match and delay by few seconds, then you start seeing the blade move in slow motion. So the same principle we use to visualize the mucosal wave or the vibration of the vocal fold. So why is it so important for us to examine the mucosal wave? Because the mucosal wave tell you the health of the vocal fold. Like Dr. Nora, Miss Nora have mentioned about the body and cover theory, okay, about the pliability of the epithelium and the Rinke's edema, which is dancing on the dancing floor, which is the vocal ligament and the muscle. So any insult at any point of the layers will affect the mucosal wave. So that is why it is important for us to examine the mucosal wave. So then, the question comes, how do we assess? So that one have been shown by Dr. Nadira. So how do we assess? When I first learned about the stroboscope, my friend, I remember Sayuti called me, Marina, how do you document the mucosal wave? What do you write on the file? Do you say good, bad, abnormally good, abnormally bad? So how do you document that? And when I assess, then the same patient assessed by Dr. Yakubu in London, how do we communicate to assess, the mucosal wave or the stroboscopic findings? So it is all very subjective, and it depends on the eye of the person who see the mucosal wave and how many stroboscopic examination that you have done. So to minimize the bias, people have developed some tools to minimize the bias, some tools to standardize the way we assess the mucosal wave. Then whenever you see mucosal wave, then your mind starts thinking, what are the things that I have to look for? So one of the tools that been used to assess mucosal wave is stroboscopy research instrument. There are many others, like I mentioned here, Hirano and Bless. There's another one by Boboruka. There are many. But the one that, at least for in our center, we use stroboscopy research instrument, SRI, which is developed and validated by Clark Rosen. So here in the SRI, you have to know, when you see the mucosal wave, you see whether is it symmetrical or not. Then we talk about what is symmetry. And then next, you look at the amplitude. How far the mucosal wave go laterally, the excursion of the mucosal wave. Then you look at the periodicity. Is it regular? Does it have a nice tempo? Tempo means tap, 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 tap. That is regular. But if something is jittery, it is not regular. It is not periodic. Then you look at the whole length of the vocal fold. Is there any part of the vocal fold is not vibrating? Then you document it. And duration of closure. Duration of closure meaning you look at the closed face, open face, and close again. Is it predominantly closed? Or is it half open, half closed? Or is it predominantly open or always open? So I will show some example later on. And the last bit is you document what is the type of closure. Is it completely closed? Or is it diamond shape? Or is it hourglass? Or is it just posterior bit which is open? So these are the things that you document when you examine the patient's vocal fold. So this mucosal wave has been explained very well by Miss Nora. The close, open, and close. So remember, close, open, and close is one Golter cycle. Someone have 190 Hertz, meaning 190 close cycle in 1 second. So this is slow motion of video stroboscopy. So that's close face, close face, close face, and now you can see the excursion. Okay, can you see the thing dancing? Alright, close, 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 and then you see the excursion. So that excursion is amplitude. How far does it move, excurse from the midline to lateral? That is amplitude. Now, before I talk about symmetry, we want to talk about one-step montage of Golter cycle, which is available in the machine that we have been using in our center, which is Pentex, which whenever the patient phonates, you choose at the beginning of the Golter cycle when the vocal fold is closed, put a rectangle box over there and do the montage. Then you get this frame. So of many frames of the Golter cycle, the machine chooses 10 frames. Okay, you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And this comprises one Golter cycle. Okay, so close face, opening, open, 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 close, 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 close. Okay, so if you look at from 10 frames, only 3, 4 frames open. So this is predominantly close. Alright, you may see half closed and half open. So we call it half closed and half open. So you go back to the stroboscopy research instrument. I found that having this one-step montage of a Golter cycle help you to assess the face closure. Then tell you, how much the patient losing the air during speaking, during phonating. Okay, the longer the vocal fold open face during phonation, the more fatigued the voice. Okay, the patient, the shorter is the maximum phonation time because there's a lot of air leak. So that is about face closure or duration of closure. Now, how do you see symmetry? So when you look at the slow motion, close, 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 during open face, you observe how does it open left and right. Symmetry means that the left and right open at the same time and like a mirror image, like that. Close, open, close, open. So that what we call symmetrical mucosal wave. You may see a mucosal wave which is one already open, the other one not open yet and become yo-yo like that. Okay, that is severe asymmetry of mucosal wave. Periodicity, I have mentioned just now, there should be a tempo, okay? So, whenever the vocal fold close at the same time, normally it means it is periodic. Whenever it open at the same time and this is mirror image, it shows that it is symmetrical. That is just a general rule. You have to see more and more mucosal wave stroboscopic findings for you to become better and better in assessing it. Amplitude, I have mentioned this now, the excursion of mucosal wave, and it will be reduced in patients who have stiffness of the vocal fold, maybe due to scar, maybe due to when there is muscle tension dysphonia. Dr. Nadira mentioned muscle tension dysphonia. Whenever the vocal fold, the false vocal fold, press on the true vocal fold, that will affect how much the mucosal wave or the propagation of mucosal wave from the midline. Right, now we talk about what are the clinical applications. Why you are so bothered of having video laryngostroboscopy? Dr. Yakubu, in the UK, for you to run voice clinic, it is a must for you to have video stroboscopy. Am I right? So it is around the world. It is a must because there are patients who come to you with hoarseness when you scope nothing. You can't see anything, especially in those cases, you need to have stroboscopy to come up with a diagnosis and to see all the little sort of thing that can't be seen with naked eye. So these are the clinical applications, okay, the list. Vocal fold pathologies. Do we need a huge vocal polyp to diagnose, like Ms. Nadira showed just now? Do you need a stroboscopy? You don't need a stroboscopy to diagnose vocal polyp. But sulcus, something that is small or something very superficial, very early stage, you would need a video stroboscopy to determine lesions that can be seen with naked eye. And also, video stroboscopy will help you to differentiate the hoarseness that the patient is having when you can't see anything on the vocal fold. Is it functional or is it structural, or there's some subtle lesion can be seen? I'm going to show there's another slide which from our observation, the stroboscopy will help you to differentiate between muscle tension dysphonia and functional voice disorder. Also, early stage of laryngeal cancer, of course, and it helps with treatment decision in certain condition. Tracking treatment progress also very, very important. So I mentioned about vocal fold polyp. You don't need stroboscopy to diagnose vocal polyp, but you need the stroboscopy to track the treatment progress. Like before you remove the polyp, you show this patient, this is how you've been speaking, that's why your voice is hoarse. After surgery, you do it again and show what is the difference and whether there's any vocal fold scar occur complicated by the surgery. So now this slide is showing you how does video stroboscopy may help to differentiate between a muscle tension dysphonia and functional. So I'm not going to tell you the diagnosis yet. I'm going to show you the video, observe and tell me which one is MTD, muscle tension dysphonia, and which one is functional. Both patients have hoarseness, different patient though. This is the first video. This is not yet stroboscopy. This is stroboscopy. I think that is enough. And the second video. There's nothing wrong with the vocal fold. Everything is perfect. The patient is talking like this. Semasa saya masih kecil, saya tinggal di kampung bersama nenek. The patient is talking. So that is the patient phonating. The voice that you heard, E is the examiner. It's like, please say E. So E is not belong to the patient. The patient is talking like this. Okay, so which one is MTD and which one is functional? Who? This is right. This is right. That is left. The right one is
MTD.
The left one is
Functional.
Okay, someone who's talking like this, and you do examination. There's no mucosal wave being generated. The patient is not speaking properly. She forget how to speak, and the larynx in locked position. So the stroboscopy not only help you to rule out any structural lesion, any organic issues, but it also help to diagnose functional voice disorder. Right. Tell me what you can see from this larynx. Again, in this course, each speaker will keep on telling you, do personal examination. Please do personal examination. What does it mean? You have to bring the camera as near as possible to the vocal fold for you to see any structural issues. For those sitting for exam, don't just do drone examination. Drone meaning you put the camera at the tip of epiglottis and say, okay, it's normal. We wouldn't put any normal cases in the exam. There must be some findings. So you put it at the tip of epiglottis just to see the panoramic view and to assess the mobility of the vocal fold. And when you're happy with that, you have to go near to see any structural abnormality. So, did you see anything? The patient has hoarseness. Now with eye scan, just now with white light, now with eye scan 3, just now was eye scan 2. Can you see anything? Can you see this? Sulcus. Okay, so that one is white light. With white light, if you're careful, you can see the sulcus. And when you use eye scan, it become more marked. You can see more obvious sulcus over there bilaterally. And on stroboscopy, this is asymmetrical mucosal wave, aperiodic. There's some part you can see the vibration because of the forced vocal fold. And there is muscle tension dysphonia. Okay, so I mentioned just now, I talked about stroboscopy. How much time do we have? Finish? Finish?
No.
Battery break. 10 minutes. Okay, 10 minutes, I go quickly. So just now was about stroboscopy. And then the last bit, I showed eye scan, right? So what is eye scan? Eye scan is an enhanced imaging technique. Eye scan is for Pentax. What about other instruments? For Olympus, there is NBI, narrowband imaging. For STORS, there is SPIES, SPIES. All have the same objective, to enhance the vasculature of the larynx, especially when there is masses. Okay. Also, why is it important for you to see the vessel? Because the vessel, the pattern, may tell you what type of lesion that you are dealing with. Is it benign? Is it pre-malignant or is it malignant? So now just a little bit of vocal fold lesion. You have seen vocal fold lesions before. It could be benign, pre-malignant or malignant, and in many instances, some vocal fold lesion is not easy to diagnose. It could be just an inflammatory lesion. It could be leukoplakia with pre-malignant lesion and so on. And the gold standard procedure is we do biopsy. Imagine if you do biopsy for a superficial lesion, very thin lesion of the vocal fold. What is the risk if you perform the biopsy? Vocal cord scar. If you're not familiar with microlaryngeal instrument, type 1 chordectomy, elevating the epithelium and the rinky space, they can end up with vocal cord scar. And the biopsy come back reported as benign, or maybe inflammatory, or maybe dysplasia, mild dysplasia, and the patient have persistent hoarseness because of your surgery, vocal cord scar. So there is a dilemma. On the other hand, if you leave it behind, you just observe, the thing may progress, become cancer. So that is the dilemma in managing vocal fold lesions. So you need a good instrument to examine lesion on the vocal fold. So having a good instrument is not a luxury, but a necessity in diagnosing vocal fold lesion. Let's say you don't have stroboscopy, you do not have eye scan, but at least you must have a video endoscopy with camera at the tip for you to be able to examine the vocal fold lesion. So I want to mention about leukoplakia. If you have a good instrument, you can categorize the leukoplakia, which one you can just observe, which one you have to quickly bring the patient to operation room and do biopsy. This classification is published by Chen in 2019, where there's a type 1 when there is smooth and flat. This is not high risk for malignancy. Elevated and smooth, there's elevation, but the surface is smooth. And the other one is elevated and rough surface. The type 3 is very high risk of malignant tumor. So this is my own collection. Remember the classification, type 1, 2 and 3. This is type 1, flat and superficial and smooth. With treatment, observation, the thing disappears. Doesn't need biopsy. The second one is elevated but smooth, and the patient is so stubborn, doesn't want biopsy. I have been observing him for 3 years plus already, so it remained leukoplakia. So that's how the confidence level that you have if you have good instrument to monitor this kind of patient. How about that one? The patient is a doctor, claim that, oh, this is just a leukoplakia, don't do anything because I had the same surgery 5 years ago and it was reported as leukoplakia, just dysplasia. But I told the patient this is irregular, and I will show later on there is change of vasculature, and I convinced the patient to have the surgery, and it turned out to be squamous cell carcinoma. So remember I said at least you must have a videoscope. The same patient on this side examined by someone else using fiberscope. Do you know what is fiberscope? Fiberscope is the one that you can detach the camera head. Okay, so it contains fiber. So the camera is at the beginning. But video endoscope, the camera is at the tip of the scope. So the image is clearer. This patient, a smoker, complained of hoarseness. Examined using a fiberscope. The doctor gave a diagnosis of laryngopharyngeal reflux. The wife is not happy, the wife is pathologist and asked for a second opinion. And the patient come to our center. This is how his larynx look like with video endoscope. It's clearer and you can clearly see that the patient has irregular lesion of the vocal fold. And when we turn on the enhanced imaging, you can see even better, and video stroboscopy shows the patient has severe muscle tension dysphonia. So a study shows that When you compare between fiber optic and high definition laryngoscopy, means camera at the tip, if you extrapolate the results, it shows that if you use fiberscope, you have a chance of 11% missing malignant lesion. Okay, you have that 11% risk of missing malignant lesion. And if you add on enhanced imaging, it will enhance the accuracy of you diagnosing the lesion, whether it's malignant or something that you can follow up, and would help you to determine the treatment and how quick you need to do biopsy. So just a little bit of enhanced imaging. I mentioned about NBI, I mentioned about eye scan. The NBI is pre-processed, where the white light is modified, so that when the light is modified, the vessel absorbs the light, and the light appear darker blue and green, so like this. For eye scan, it is post-process. It take photo and it modify the contrast. So remember, what is the most important thing about enhanced imaging? To examine the vasculature. So you use NBI, you use eye scan, your spice. What you want to look at is at the vasculature. Why is it important to examine the vasculature? Because according to this classification, there's another classification, but I just focus on this. According to this classification, the vasculature pattern will help you to determine whether this is benign, pre-malignant or malignant. So the type 1 is longitudinal, type 2 is perpendicular. I will explain you what is perpendicular. Type 3 and 4 is perpendicular, 4 is worm-like. So when we talk about perpendicular, means there must be a lesion. Okay, some of my registrar, oh, there is perpendicular lesion, but there's nothing on the vocal fold. There's no lesion. So you see perpendicular lesion, perpendicular vessel when there is a mass. And you want to see how does the vessel look like on the surface of the mass. Okay, this is a cross-sectional view of vocal fold. That is muscle, that is the base, the vessel on the vocal fold, that is lesion. So when the vessel feeding the lesion from below, you see from the top, your scope from the top. So perpendicular, you can see dots or spiral or 2 dots on the surface. So this vasculature is called IPCL, intraepithelial papillary capillary loops, that could be secondary to cancerogenetic stimulus. So I've shown you this leukoplakia. It looks leukoplakia, right? And focus on this lesion. Can you see the perpendicular vessel? Okay, so the vessel comes from below and you can see dots on the surface. And if it is a pre-malignant, you would be able to see 2 dots at the side, 2 dots, 2 dots, 2 dots at the side. We call it symmetrical arranged dot-like loops. And whenever the mass here, malignant, the perpendicular vessel become spiral. Okay, as you can see, like a worm-like lesion. So in our center, if we see this, we tell the patient, without biopsy, I can tell you that this is malignant lesion. So now just a little bit on early gothic carcinoma treatment. I don't think we have time for this. I just want to show you a case presentation. Pre-malignant or malignant. The same case that I showed just now. A patient with leukoplakia. On the right side, it looks irregular. And on a close-up view, can you see this? Is it obvious? The vascular pattern over here. It looks like spiral. That one is covered by leukoplakia. You can't see the vessel. And there's a few parts where the vessel looks spiral, type 4. And on stroboscopy, please focus. Compare right and left vocal fold. what do you see on the left? Number one, the mucosal wave is asymmetrical. The amplitude is reduced on which side?
Left side.
On the left side. Is there any non-vibratory segment? There is, which this area, although some like this, but there's no excursion of mucosal wave. So, in this case, you combine the eye scan findings, the vascular pattern, and the stroboscopy, you can confidently tell the patient that most likely this is a malignant lesion and it has involved deeper than just the rinky edema. It has, not rinky edema, rinky space, okay? And this patient undergone surgery, type 2 chordectomy, and it turns out to be squamous cell carcinoma. I think the time is, I have few more, but I'm not going to discuss. Maybe the last bit, the conclusion. Conclusion? Yeah. The conclusion, video laryngostroboscope is an important tool for you to assess vocal fold patient with voice disorder, especially when you can't see any lesion, especially when you can't see any obvious lesion, any structural or any obvious neurological like vocal fold immobility. And what is stroboscope? Is when laryngoscope combined with stroboscope with flashes of light emitted on the phonetic vocal fold so that you can visualize the vibration. So this is video stroboscope. And it is mandatory for you to use stroboscope in patient with voice disorder, and it is also a useful tool for you to differentiate between pre-malignant and malignant and benign lesion, especially when you combine it with enhanced imaging. And in this case, if you use Pentax, it's called iScan. If it's Olympus, it is narrowband imaging, and there's other names for other company or instrument. Right. So thank you very much for your kind attention. You have any question? There's Slido, right? Slido.
Thank you so much, Prof. Marina, for the enlightening lecture. Ladies and gentlemen, it is now time for our morning break. We have 20 minutes and the food will be